Let's get started. First off, we're going to be talking about myocarditis. You need to understand that myocarditis and pericarditis are a continuum, and sometimes these are both referred to together as myopericarditis. The changes on ECG are very nonspecific. Sometimes it will mimic a STEMI, sometimes it's just going to give you nonspecific SDT wave abnormalities, and sometimes it can present with pathologic Q waves. The other findings of myocarditis on an ECG are that it can present with tachydysrhythmias. Alternatively, it can also give you atrioventricular blocks as well. Another finding of myocarditis on an ECG is going to be the fact that you will see low voltages similar to how you saw in pericarditis. You can also get increased QTC interval because the inflamed myocardium is going to damage the depolarization and repolarization. It can also cause increased QRS duration as well. Let's take a look at this ECG. You see deep pathologic Q waves in lead 3. You can also see some ST segment elevation in lead 2 and AVF, V5 and V6. There's ST depression in lead V1. Initial tall positive R waves are not supposed to be seen in V1 and V2, but these signify pathologic Q waves of the posterior wall. This was actually myocarditis proven on an MR. Let's move away from myocarditis for a second. Let's talk about pulmonary embolism. I think that this is the most controversial subject when it comes to reading ECGs. No one wants to believe you. Anything that puts pressure on the right side of the heart is going to cause these changes. There is significant amount of overlap between the changes on an ECG from pulmonary embolism and any sort of pulmonary disease pattern. The most common finding on an ECG for pulmonary embolism is actually a normal ECG, so a high index of suspicion is needed. Sinus tachycardia was found to be in 38% of cases according to a meta-analysis and systemic review. You can also have ST elevation in AVR, which was present in 36% of cases. Another finding was T-wave inversion in V1, which was again present in 38% of cases. You can get T-wave inversion with pulmonary embolism in the precordial leads and the inferior limb leads. Of course, it is putting pressure on the right side of the heart, so you are expected to see some degree of RV strain in the right-sided leads. That means that initial tall positive R complexes with ST depression and asymmetric T-wave inversion. Again, since we're putting pressure on the right side of the heart, you can get the clockwise rotation of the heart, also known as right axis deviation. That is followed by the infamous S1, Q3, T3. Now what that essentially means is that you have a deep S wave in lead 1, a deep Q wave in lead 3, and a T wave inversion in lead 3, hence the name S1, Q3, and T3. Note that this was already present in 20% of cases with pulmonary embolism. Again, you can also see complete or incomplete right bundle branch block in patients with pulmonary embolism, and that was present in 18% of cases. One more thing I'd like to point out over here. A study by Kosuke et al. In 2007 showed that 88% of patients with pulmonary embolism had a combination of finding of V1 T-wave inversion, and lead 3 T-wave inversion. Let's look at pulmonary disease patterns now. I want you to think of three things. Number one, a right bundle branch block. Number two, it's putting strain on the right side of the heart. And number three, anything that causes hyperinflation of the chest or lowering of the diaphragm will cause clockwise rotation of the heart, also known as right axis deviation. We've already discussed RV strain. You get tall positive initial R waves in V1 and V2 with asymmetric T-wave inversion and ST depression. This pressure is going to be transmitted upwards to the atria as well, and you will have a P pulmonale. I've already discussed this in my video on P waves. Imagine this to be the heart. Your RV is significantly dilated as compared to the LV. Now let's draw a frontal plane of the same image. More musculature, more dilatation exists on the right side of the heart this time. Also, since the right side of the heart is being dilated, there is clockwise rotation of the heart, which causes right axis deviation. COPD, emphysema, long-standing asthma, pulmonary embolism, all of these things will cause similar changes. In emphysema, you can also see electrical alternance. That happens only because there is a significant amount of distance between the chest wall and the electrical current, and that changes when the patient breathes in and out. A combination of all of these findings is very suggestive of a pulmonary disease pattern. Another small point would be not only to calculate the axis of the QRS complex, but to also look at the axis of the P wave. That gives you an idea as to how the depolarization is happening in the atria. Poor R wave progression is also another symptom of pulmonary disease pattern, and that happens because a lot of the electrical current is flowing towards the right heart, and it masks the current that is flowing towards the left heart. So, poor R wave progression is seen in the precordial leads. Here is a visual representation of the same thing. That's all for today. Let me know in the comments section if this was helpful or not. Don't forget to like, share, and subscribe to the channel, and have a good day.